Bethan.
So good morning everyone. Before we start the meeting, exactly 7 days ago we were all hearing on the news that there had been a large incident in Nottingham, and at this point in time I don't think it was confirmed what had happened. I think we should have a minute's silence because it is just a week ago. So can we all stand please for a minute's silence and remember everyone who was involved. Thank you. Thank you everyone. Right, so moving on. Point number 1 on the agenda is to note the appointment which was made at full council of myself as chairman, Councillor Bethan, Eddy as vice chairman for the ensuing year 2023-24. Okay, everybody noted that? Good. And to note the membership of the committee: Councillor Mike Adams, Councillor Sinead Anderson, Councillor Callum Bailey, Councillor Steve Carr, Councillor Kate Foale, and Councillor David Martin, Nigel Turner, Michelle Welsh, and Councillor John Wilmott. We have some change of membership for this morning. We've got our usual, and mind you, I don't think you're substituting this morning, Councillor Pringle, are you?
No.
You're just here.
No, madam, just allowing me to speak.
We have Councillor Creamer as a change.
Sorry, just to confirm that the membership, since the publication of the agenda, it's been confirmed that Councillor McGrath is a full-time member of the committee for 23-24 in place of Kate Foale. So that's just to note in addition to what was published last week. Thank you.
I have to say, I thought you were a permanent member, Councillor McGrath. Just occasionally you weren't able to come.
I don't get involved in politics.
Right, that's fine. Apologies for absence. Martin, can you confirm apologies and substitutions, please?
Just an apology from Councillor Welsh, with Councillor Creamer substituting.
Thank you very much. We haven't got Sarah here this morning.
No, we've apologies from Sarah as well, Sarah Collis.
Oh, okay, thank you. Declarations of interest, members and officers. Have we got disclosable pecuniary interest, anybody? Yes, Councillor McGrath.
My daughter's training to be a nurse, Chair.
Right, thank you. Anyone else? Councillor Eddy?
My husband's a community staff nurse.
And I will give interest as always because my daughter works at NUH, and I see somebody here this morning who will know my daughter extremely well. So definitely interest from myself. Okay, so meetings of the last meeting held on May the 9th. Do everybody confirm they're present and correct? Yeah, I can sign them as a true record. Good. So we've got 3 people from the diabetes unit at NUH today, and we have, let's have a look, we have Hazel. Did you come to us before, Hazel? Yeah, I thought you did. Yes, I recognised you from before. And we have Tabitha. Good morning.
Morning. I'm a consultant in paediatric diabetes and project NUH, and I'm the NHS and Midlands clinical lead for children and people with diabetes 0 to 25.
Thank you. And Dr. Mohan.
Yes, I'm a GP here in Ruddington Medical Centre. So a local GP who also happens to have a specialist interest in diabetes, and I lead various diabetes initiatives.
Excellent. Excellent. Welcome to you all. We're looking forward to your briefing. So who is going to start with this? Are you?
Just a reminder to use microphones. Thank you. Oh, it's probably a new system since you were last
Yeah,
here.
sorry.
So yeah, it's fine.
I'll start with a brief presentation and then I'm going to hand over to my clinical colleagues where they'll give a bit more information for children and young people, and Rahul for adults, and then we'll open up for questions.
Lovely. Thank you. So the floor is yours.
Okay, thank you. And then do I just say next slide when it's to move on? Okay. So what we're going to cover is just a really brief overview of the population profile, actions that we're taking as part of the transformation program and overall. And then, as mentioned, we'll have then clinical colleagues will provide some additional information. And I know you're particularly interested about the impact post-COVID, so we just try and touch on that as we're going through the agenda items. So if we go to the population profile, so prevalence of diabetes is increasing year on year nationally. Diabetes is a hidden condition, and if it's left untreated or undiagnosed, it can cause serious harm, affecting every organ of the body, and damaging the cardiovascular system, blood vessels, and organs. So it's really important that we have that focus on prevention as well as the management of diabetes. In children and young people, it is an aggressive condition, resulting in early onset and more severe complications. Across Nottingham and Nottinghamshire, it's estimated that there are about 1,500 children at risk of high blood sugar, and so it's not something that we can ignore. So if we look at 15 and over, for pre-diabetes, there's approximately 57,000 people in Nottingham and Nottinghamshire who've been diagnosed with pre-diabetes. And you'll see that there's a higher rate in mid-Notts in particular, or mid-Nottinghamshire in particular. For type 2 diabetes, there's approximately 70,000. And we know that type 2 diabetes is wholly preventable. We do have a higher prevalence in Bassetlaw and Mid-Notts, and so again, these are areas of focus. And then for type 1 diabetes, there's approximately 6,000 people in Nottingham and Nottinghamshire. So if we look at the next slide in the transformation program and actions that we're taking, we look at these across prevention and self-care, primary care, our community services, and secondary care. I'm just going to split them down into education, services, and prevention to give you more of an idea of what we're taking forward. So in relation to education, we have got the NHS Diabetes Prevention Programme. That is a programme that is offered nationally, but very much locally focused and locally procured. So we are able to look at how best do we target specific neighbourhoods, specific populations, and with that, how do we really make sure that the services are accessible? We have structured education programs, and these are different for type 1 and type 2. And again, there's local programs that are offered, as well as national programs. The national programs are online. There's just one that's recently or this year being offered, which is Healthy Living for type 2 and My Type 1 Diabetes. We know that take up of those programs isn't at the level that we'd like it to be, and so there's more work that's happening around how do we make these more accessible. Again, really, what can we do locally, and how do we make it accessible based on the different communities, and really reaching out to individuals. We've got education programs for primary and secondary care staff as well, and community staff. So we have put on and made training accessible so that we're really increasing the knowledge about diabetes across our services. When we look at the services, we've been putting in more funding into diabetic specialist nurses in secondary care, and that's to both work with the wards and educate staff, as well as seeing patients. And with our GP practices, we've been working with the diabetic specialist nurses to understand how they can work more effectively, and hold joint clinics with our GP practices. Foot treatment is really important for diabetes, and I know last time we talked about expanding our current foot care services so that we have specific skills in podiatrists focusing on diabetes, and that's in place. We do have in Nottinghamshire, a higher than England average for hospital spells due to diabetic foot disease. So it is something that we want to really get at the front of, and really look at how do we focus on prevention. So it is again reaching out to people at an early stage, and identifying any risks. For diabetes, there's what we call the care processes and treatment targets. So these are defined by NICE and our annual checks that should be carried out on all diabetics. So we've put in place a program with our GP practices to support them to increase access, and increase the uptake of the care processes. And recognizing that in some areas the practices may have more challenges in engaging with their local population, or individuals aren't accessing their local population. And this is in particular the areas of deprivation. We've provided those practices with the higher number of diabetics, and where the practices are in the higher areas of deprivation. We've provided them with additional funding for them to put together an action plan that is relevant to their local community, and where they can really reach out to them and see what more they can do to make sure that they're having the individuals are undertaking the care processes. And in relation to prevention, we've got a perioperative program. So that's a program where there's a specialist team will see individuals who have a high sugar reading prior to surgery, and work with them and how they can manage their diabetes more effectively, manage their weight so that their surgery isn't cancelled, but then also to help to manage complications post-surgery. That's a really important program that's a pilot at the moment, and we're looking to expand out further. We've got a low-calorie diet program in place, and again that targets diabetics, and that is through the GP practices. And it is really it's a really intensive program. Again, something that's nationally commissioned, but it's how we apply it and roll it out locally. There's also the NHS Digital Weight Management Service, and we put in additional resource to really promote that service, and that again is for diabetics. It does cover other conditions, but we're particularly focused on diabetics. And we're looking to increase access to continuous glucose monitoring. So that's where you may have seen things like Flash advertised, where people can have real-time monitoring of their blood sugar levels instead of taking the finger pricks. So it's how do we really expand that out and reach out to all those who or who are entitled to the what we call CGM on the NHS. And then in relation to children and young people, this diabetes is part of what we call, next slide, sorry.
Oh, yeah.
Diabetes is part of what we call the Core 20+5. So the Core 20+5 is the national framework around health inequalities, where there's a specific area for children, young people and diabetes. And that's, again, increasing the access to the continuous glucose monitoring and make sure that all our children are taking advantage of that, as well as insulin pumps and having annual health checks. We've got a transition service, so that's where for our young people and really supporting, looking at how we best can support them in managing their diabetes at a crucial time. And that's a pilot through Sherwood Forest Hospitals, but then we're also developing a program with Diabetes UK, and that's around lived experience, again, for the young people, and this is specifically for 19 to 25-year-olds. And we're working with primary care to make sure that all the young people with diabetes under 25 and under are under the care of a specialist team. So that's Tabitha's team, because it's crucial that they've got that oversight. And we're also reviewing the approaches to prevention and weight management in children and young people. So that just gives you a snapshot of all the programs that are in place. So I'm just going to hand over to Tabitha to give you a bit more detail around children and young people, and then Rahul is going to talk to you a bit more about adults and post-COVID.
Thanks, Hazel. So in Nottingham, we've got one of the biggest children's diabetes centres in the country. We now look after over 420 children and young people with diabetes, which sounds like a very small amount when you consider the number of people across the county who've got diabetes. But one of the things that we have seen during COVID and since COVID is there's been a big increase in the number of young people with a diagnosis of diabetes, and particularly in the young people with a diagnosis of type 2 diabetes. I've been in Nottingham for 18 years. When I first came here, I had 2 young people with type 2 diabetes. I now have 25. Again, sounds tiny, but we have seen a trebling of numbers of children being diagnosed with type 2 diabetes since COVID, and it's entirely weight related, which means it is an entirely preventable and reversible condition. If you develop type 2 diabetes in young adulthood, and by young adulthood we class anyone under the age of 40 as young, it is a much more aggressive disease. If you get type 2 diabetes when you're in your 60s, it's usually manageable by lifestyle changes. If you're getting it in your 20s and your teens, we have got to get in there, and we've got to get in there early, because the complications of diabetes that people are aware of, such as eye damage, kidney damage, heart attacks, are far, far more likely to happen if you have type 2. And of course, the other thing we're dealing with is that this is a cohort of young people, and over half of them will be women, because it's type 2 diabetes is more common in girls and young women than in men, which is slightly different with the older demographic. Is that this is a cohort of people who are potentially going to want to get pregnant and start a family. And if you have diabetes during pregnancy that is not well controlled, that can have serious health consequences for the mother, but also for the developing baby. And a study from America showed that 50% of young women with type 2 diabetes who went on to get pregnant had an adverse pregnancy outcome. So in other words, these were pregnancies that either didn't go to term, or the babies were born stillborn, or had serious congenital defects. And all of this, again, is entirely preventable. And this is where so we can work with young people who've had that diagnosis made. We can support them. These, by definition, these are often from families who have a lot of additional challenges going on in their lives. These are families that often are in the bottom socioeconomic deciles in terms of deprivation. They are far more likely to be from black and minority ethnic groups because genetics is a big determinant as to what age you get type 2 diabetes. And so that is a lot of extra resource that is required to help support these families. And as a health service, we can support them to help them with their treatment, but we need to do something to try to stop the rising tide of obesity that we're seeing. During COVID, the number of children in year 6 that were overweight or obese in Nottinghamshire went from 20% to 25%. And it had been steady for 7 to 8 years before then. We saw this 5% increase. And just as a bit of an anecdote, I've got a little girl who was diagnosed with type 2 diabetes 2 weeks before her 10th birthday, who during the 18 months of lockdown gained 55 kilos. That's 9 stone in 18 months. Now, that is a very extreme example, but what we have seen is that rise in obesity has dipped a bit since children have gone back to school, but it has not returned to those levels. And we've got to do something at a system level to address childhood obesity. This isn't just, it's too late when they come to us, and we've got to be doing something much, 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 much earlier. This is a pre-health issue. We don't have programs for children to help with weight loss. We don't have a pre-diabetes program. We've done some data analysis at work at NUH, looking at blood tests that GPs send through, and there's a blood test that tells you your risk of developing diabetes that is just done routinely for a variety of reasons, and the number of children in that pre-diabetic range. So if you're an adult, you could be plugged into a pre-diabetes program. There is nothing for children because this hasn't been a problem. But if that number that we've seen on blood tests is extrapolated to the whole population of Nottinghamshire, as Hazel mentioned, we are looking at potentially 1,500 children and young people under the age of 18 at risk of developing type 2 diabetes in the next 10 years. This is a massive, massive health time bomb, and we need to do something as a system to help support these families. What are we doing in school? Where are we? What's the access to vending machines? What food is being offered? Where are the safe spaces for children to play? How do we get out there? Because the type 1 I can't do anything about. I can't prevent it. We can look after those young people. We can provide them with new technology. Type 2 is a preventable disease, and that's what's got me really worried at the moment. I'll hand over to Rahul now.
Thank you, Tabitha, and thank you, Hazel, for that presentation. And what I'm going to be talking about is that why COVID-19 really had that impact. And the COVID-19 pandemic has been an unprecedented occurrence, and the impact which it has had on the patient's life has been just enormous. And just to make a comparison, it was seen that in a natural disaster like Hurricane Katrina in US in August 2005, it was seen that the impact on the people who were living with diabetes was even seen 18 months after the event. And Hurricane Katrina was only for 8 days. So just imagine the impact of the COVID-19, which is going to be there on our patients. And we as health professionals are going to be dealing with this as for a very foreseeable future. Diabetes was one of the commonest comorbidities which was seen in people who were hospitalized due to COVID-19. And its occurrence was even higher than the chronic lung diseases like the COPD and the bronchitis, asthma. So there was a very interesting survey which was done locally to see the impact of the COVID-19 on the routine care of the chronic diseases. And this was done by among the healthcare professionals by the National Institute of Health Research, East Midlands. And it was not surprising that diabetes came on the top of the condition where the impact was the most among all the chronic conditions. And this was due to the reduction in the healthcare resources, which were because of the COVID-19. Basically, what COVID-19 has done is that it has exacerbated the health inequalities and health disparities which existed in the system. And there is going to be a very significant
downstream impact of COVID-19. And personally, I've seen the percentages of the patients who are living with type 2 diabetes who could be classified as uncontrolled. And here, what we are doing is that we measure their HbA1c, which is a measure of their diabetic control. I've never seen in my life triple digit HbA1cs, which signifies a massively uncontrolled level as compared to before. We have a national diabetes audit data which looks into the diabetes care which is being provided by all the GP practices in Nottingham and Nottinghamshire, and they look into the three treatment targets and the 8 care processes which Hazel had talked about, and there was quite a substantial drop. Literally, the practices, the level of care fell off the cliff during the COVID period. So that was the level of impact which the COVID-19 had on the people who were living with type 2 diabetes. So personally, I've had examples of very advanced diabetic retinopathy where people lose their sight, people having uh, leg ulcers and leg amputations because they have waited for a long period before they sought medical attention. So I think what I would say is that the COVID-19 has really made one thing obvious is that there is a need for good glycemic control. And even 1 year of poor glycemic control or poor diabetes control led to a significant increase in the diabetes related complications. So what we can do is that COVID-19, we can utilize it to our advantage, that we can use it as a catalyst to bring about some changes, to bring about an increased use of technology. And what we can do is that we can incorporate a digital care model, which can be incorporated into that traditional chronic care model. Thank you for listening, and we are open for questions.
Well, thank you very much for the briefing. I'm sure the members of the committee will have some questions to ask you. Councillor Creamer's got his hand up already. Just one thing I was going to ask. Tabitha, you mentioned how the machines in schools where they can buy sweets and crisps, etc. I dare say the children got used to eating that kind of thing during the lockdown when they were at home and they just ate sweets and ate crisps. Are the schools cooperating with you in this?
So we don't have any access into schools to ask about this. This is it's outside our remit, which is one of the reasons I was so keen to come along and talk to you guys as the members from the ICS and feeding into education. Now I appreciate we've got the challenges with academies, etc. But one of the problems is that a lot of schools rely on these vending machines as a source of additional income, and we're just as bad. On our vending machine in the middle of the children's hospital, we've now got 2 vending machines, and it takes plastic, so there's anyone could get at it, and there isn't a single healthy option in there. If I had my way, it would offer water and tell them they can go and buy an apple if they walk down 7 flights of stairs, but that hasn't been terribly popular. But it is a really, really worrying issue, and young people are no better at making sensible, healthy choices than adults are. So I don't know why we expect children to walk past a vending machine and go, "Oh, I mustn't have a sweetie, that's bad for me." We need to be making sure that the options there are appropriate options for them, and we're not helping at the moment.
So presumably you're relying on people such as ourselves, who may be governors of schools, maybe parents of schools, to pass these messages round to try and reduce the amount of vending machines in schools.
We need it as a system-wide approach. We need it being out there in the education thing and asking and the school meals. Who is commissioning school meals? School meals themselves are generally fairly healthy, but it's the options you have. When my children were at school, they moved to a system where you could actually see what they were eating. And when I realised that my daughter was having Coke and pizza every single day, she no longer had school dinners, and I made a packed lunch for her because she wants to be the same as all her mates. And if they're all going to have pizza and Coke, you're going to have pizza and Coke. and it's the whole Jamie Oliver thing. But it is a societal thing, and it's all for primarily this is food related. This is not about exercise. That's very important, but you have to run for 45 minutes to burn off one biscuit's worth of calories. So you don't need to have very much more than you need to gain weight. And if we are not giving young children and young people a healthy start to life, and families know how to cook and all the other bits and pieces, that's a whole separate issue. But things that we potentially could control as a system or influence as a system, I think there is more that we could do as a system.
Thank you for that. Councillor Creamer.
Thank you, Chair. I've had several questions. Most of them I think have been answered to some extent or not, including the last one, which is I was actually thinking about Jamie Oliver and the turkey twizzlers and what have you. And when the parents were actually told they were getting healthy foods, they actually came to the gates with putting chips and burgers through the bars. So it is a matter of education all the way through. And I'm wondering if there's any sort of money or thought going into the education of parents. I mean, quite rightly about the actual school meals being healthier, at least options, at least one of them will be healthier, if not all, as you've already said. But the price of food is going up. This council's putting has put the price of school meals up. The academies have put the price of school meals up in a crisis. So actual junk food, you can't blame in one respect the parents for feeding them junk food because it's cost, and that's the only thing. That's what they can afford. So is there any way at all of actually not just about education, but supplying some sort of help, either through ourselves, yourselves, or some sort of partnerships to actually make sure that the actual right foods can be provided along with the education? Because it's all right knowing that this is the right food, this is what I can afford.
So I just would like to come back. This is a recurrent myth that is peddled, that it's too expensive to eat healthily. It's not. That's not the case. What is expensive is to eat healthily if you don't know how to cook. And actually, it is much, much cheaper to buy fruit, veg, lentils. Who eats lentils? Those kind of things. You can eat very healthily, but if you don't know how to cook and you're worried that if I buy this food, my children aren't going to eat it, you can understand why people take the option of the junk food. But it is a myth that it is more expensive to eat healthily than unhealthily. But there is a whole other issue around that. It's like, if people don't know how to prepare food, they don't know how to cook, it's much easier to buy in some beige food into an oven. And so again, is there something? There is no money. So there is no money at all in the NHS. We're bust. We're totally bust. And the constraints we've got at the moment, and this is why it's so disappointing, and again, obviously way above what we can do here, that the national strategy on obesity has been kicked into the long grass, because it needs to be at a strategic level. But it would be really good if in Nottinghamshire we could look at some innovative ways of perhaps helping for providing cookery meals, and then of course you've got to try and engage families to want them to do it. So we have attempted to do that, providing cookery classes for our families with type 2, and it's safe to say that the uptake is low, as in non-existent. So there are lots and lots of things and lots of challenges along the way, and certainly the cost of living crisis is not going to help. If you've got a finite budget, you want to make sure that your children are going to eat what they put in front of you. But if you don't know what to get, and it's most of the children that I see, they are eating the same thing as their parents are eating, which is no fresh fruit, no veg. And if you don't eat that as a parent, and you're not sitting down together and you're not eating together, you're not going to model that healthy eating behaviour.
Yeah, so come back on that with. It's part of the issue as well. Is time as well. Parents are actually working, trying to make money, etc., and actually having the time to cook is another thing. So I'll agree partially with that, but it is a real issue. But just on going to the adult side more than anything else, because I perhaps should have declared a little bit. I'm actually a type 2 diabetic anyway. But the actual the primary care, for instance. I mean, do we have actually enough nurses? I mean, my surgery is in a high deprivation area in Greenwood, Sneinton and Greenwood. But we've got shortage of diabetic nurses, etc. So I'm just wondering about this increased training you've got at secondary level, at the primary level. I mean, my appointment was cancelled on Friday and moved because the nurse that they put me with didn't know how to use the insulin bit. It wasn't trained in that bit because there's only one. So now it's been moved to July. So I'm still going to get it, but it's delayed. So when you're saying you're actually improving stuff, all I can see at my level, not it was combative, but it's slowly reducing. It's getting more difficult to see a diabetic nurse, and it's mainly the nurses that deal with it rather than the doctors. Well, certainly in my case over the last 15, 20 years. So I'm just wondering what extra is actually going into the deprived areas and high output areas, as we call them, to actually improve the access, because that's part of the issue. When you've actually got to identify in the first place. And I've got to admit, my doctor in the past, when I turned up for anything, used to give me a blood just to see if I was diabetic or not, long before I was. So I've got no problems with the actual treatment. It's just once actually found, it seems to be more difficult to actually get the appointments, etc. So I'm just wondering, are you improving that, and particularly since COVID? And I think that's where the practices have changed how they operate, regardless of the usual complaints about can't get in at 8 o'clock, etc., etc. So things have changed massively since COVID. So on that respect, are you trying to actually get more nurses in to actually help with the diagnosis and help with the treatments on the primary level? And as we actually go on, just in general statistics, we've already mentioned how it's gone up. Was it 25? It's gone up quite a lot during COVID. Is it still declining? Is it starting to peak? I know you think things are getting worse for children, but for the adults, is that still increasing? So that's my general question. Thanks.
Yeah, I think that's a very pertinent question. And the question is the DSNs are like the diabetes specialist nurses are like gold dust. They take more than 18 months to 2 years to train. And a lot of diabetic specialist nurses are reaching that age where they are retiring. So yes, the Nottingham ICP is trying to broaden the base of the healthcare professionals who can look after the people who are living with diabetes. So there is a pilot project which was run in the Nottingham city with regards to involving the healthcare assistants, the social workers, and there is an increasing emphasis now being placed on some education models so that we can broaden this base of the people who are looking after diabetes, people who are living with diabetes. So your question that we would definitely want to broaden the number of the DSNs that we have in Nottingham. And I think that has always been one of the priorities in Nottingham and Nottinghamshire. So that is something which is there. There are going to be the use of technology is something which is going to really come quite handy, and especially for people who are living with insulin, because whatever we do, the healthcare professional, the contact of the patient with the healthcare professional is only 4 hours in an year. And for the rest of so many thousands of hours, they're living on their own. So bringing the technology to which would give them that feedback of how their blood sugar is doing is something which is going to be really quite handy to help them to really make what food choices is right. So having the CGM is going to give them the instant feedback that yes, this makes your sugar go up. This sort of physical activity is going to bring your sugar levels down. So there is going to be more help. But I completely take the point that the number of DSNs that we have currently are quite inadequate. And yes, we would have loved to have more DSNs.
Sorry, just to add to that part of so we are looking at how we can also educate GP practices more so that the specialist nurses are specialists, and then the practices have more the skills to manage diabetics, and that's where we're doing things like joint clinics so that the practices are learning more about, as Rahul was saying, being educated more around managing diabetes. There are the challenges around capacity as well. So it is a combination of factors as to how do we make make it more specialist? How do we keep more accessible? How do we keep the diabetes specialist nurses specialists and have skills to support the diabetics? So we're always saying it is a combination of things that we are looking at in that context.
And I'd just like to say, I'm so a member of the Diabetes UK Professionals Council, and this is a nationwide issue around diabetes specialist nurses, so which has been recognised by Diabetes UK. And we've been having discussions as to, well, how do we make this a career that people want to go into? How do we make it interesting and exciting, and for people to see that this is somewhere we can make a real difference and really change people's lives? I think diabetes is the most exciting thing on the planet. I appreciate not everyone shares that same opinion as I do. And I can go home at 5 and forget about it. So it's about how do we get that knowledge and that information out there, because as Rahul says, if our current cohort retires at the moment, we haven't got a queue of people coming through. So we need to think creatively, and I think we're going to need a lot more. As Hazel's mentioned, we're doing a lot more virtual things in terms of training. There is going to be a lot more accessibility for people to access training in their own time, that aren't reliant on always having a specialist nurse available on that time. You might not want to be there at 10 o'clock on a Tuesday morning. Actually, having a quick look at a video of 5 o'clock on a Friday might suit you better. So how can we make sure we've got that accessibility?
Thank you. Does that answer your questions?
It does, but if I just come back on one bit, really short of that, they also short to some extent volunteers. I mean, the only diabetes support group which I was in was actually not my surgery, but it's the Peacock surgery on Carlton Hill, and it was volunteers, and they had to stop just before COVID, so it wasn't related, but just before COVID, for the simple reason they couldn't actually get nurses, doctors to come and speak to us, because although they were volunteers, and although the Peacock surgery gave the room for free at night, everybody that came to us was actually a volunteer nurse, a volunteer doctor or clinician who came to give us their expertise and what we were doing wrong, etc. So that was a very useful group. But since that's closed, there's nothing else. And it's groups like that perhaps you need to be supporting as well, by at least paying a nurse, paying a doctor, so they can actually go. I mean, we got one very nice nurse came all the way from Sheffield just to speak to us. But again, it was volunteering, and it was her own time. So support groups perhaps need to look into, particularly for the adults. I'm not quite sure if they'd work as well with the younger generation, but they may.
There is a support group, as far as I'm aware, that's been reset up, because we have a representative on our regional steering group, don't we, from the Diabetes UK thing. So if you go to the Diabetes UK website, it's a really useful resource, and they will signpost you to local support groups. There's definitely one in the Nottinghamshire area that's restarted. It's a much broader one. And we're clearly not signposting them well enough, so we need to work out how we can get that information out there, because obviously that information is not getting to people who need to know about it.
But was that, so come back again, but was that since COVID? Because it was that actually sent me to that group, which was the only one.
Yes, so this has definitely been re-established since COVID, because he was talking at our group just a couple of months ago.
Yeah. And what I can say is that I have spoken over to a lot of support groups like what you've mentioned locally here in Rushcliffe, because that's my area of practice. So I've gone to 3 support groups locally in Rushcliffe, but I would be more than happy to come to your group as well to speak.
If it could get re-established, I wasn't the main character, but I'll let her know.
Thank you for answering those. Councillor Wilmott.
Thank you. I think we've got a very serious problem on our hands. It seems really that obesity rising, people for physical activity, people seem to be doing less. I don't know why that is, but we seem to we've got to get the people to change their lifestyles. Otherwise, the rise in diabetes will carry on to such an extent and of course it's a problem to vacancies in your area. I know that recruitment and retention. I just wondered if you were doing anything about that. And as I say, it's a very difficult situation. Takeaways they're rising so fast. It's unbelievable. And the food that they're preparing is loads and loads and loads of calories. You're going to get more and more problems. And I can't understand why supermarkets don't have a special stand for people, you know, to lose weight, to combat dietary problems and also diabetes. You know, I can't understand why we're allowing that to happen. Is it just because of money, money, money? Just money talking all the time? Because you're absolutely right about it. It is a fallacy that good food is too costly. It isn't. It isn't. If you look at the right things and buy the right things, and also, I'm afraid nobody seems to be cooking at home. That's another major problem. Probably, are we learning at school? The teachers are providing lessons on cookery as much as what it was. I don't know. You know, it's a very, very serious situation. On paragraph 3.22, highlights the fact that there are increasing amputation rates and increasing emergency admissions due to diabetes. I was just wondering, the statistic contained are only in 2021. I just wondered, is there any up-to-date figures available on that? And the data from 2021 also states that the largest increases in amputations occurred in South Notts, 52 compared with 32 in 2019. We hear in meeting after meeting about the health inequalities that exist in Nottinghamshire between the north and south of the county and the north of the county, especially places like Ashfield and Mansfield, where we're worse off almost all health statistics that we seem to be worse off. Is there any reason for that anomaly? Because it needs to be addressed. And of course, you've got down here that you've diagnosed with diabetes 3.9 million people, 90% in type 2. And in addition, there are almost 1 million more people living with type 2 diabetes who have yet to be diagnosed. I just wondered how you estimated, how have you come to that assumption situation? And as I say, it is a really serious situation. And as on research, has any been undertaken in respect of the longer term effectiveness of the NHS low calorie diet intervention? Obviously, low calorie diet is the thing to have. Are you actually putting out the message out there anywhere to let people know about this situation, about this possibility? Because yes, it's out in a lot of organisations, but it's very, very costly, and as I say, money's short, in short supply and difficult to get. I just wondered if you could help us on that. And as I say, it's a really serious situation that I think now it's time that the government took some more steps to address the situation, because if you said you're nearly bankrupt in resources, that should not happen in the NHS.
Who's going to answer that one?
Well, there's quite a few there, so I'll
list there.
start, and then so in relation to the health and well-being of the population, we have the joint health and well-being strategy, and I think it's really how do we bring diabetes into the forefront as one of the risks to our local communities, and what more can we do to really highlight that? And it is looking at all. There is a lot of things that are happening through the local authority and that are supported through the NHS, and it's what more we can do across as a system, which Tabitha was talking about earlier. In relation to foot care, the data that is the most up-to-date data. It's a national database, so we do look at locally also to try and understand. To try and understand what is happening, as I mentioned, locally, and it's because of the numbers that we've put in the additional resource into the specialist diabetes podiatrists, and having that as part of the community foot care service. So we are focusing on those amputation rates. in relation to the low calorie diet, there's specific criteria to be referred into that, but to make sure that people are aware that that is an opportunity. We specifically have a diabetes nurse who's um, calling around people to talking to them about their diabetes and the opportunity to access low calorie diet, so that we are proactively reaching out to those who are able to offer who are able to take part in that service. It is evidence based, and it's evidence based in relation to diabetes, but it's within that specific criteria. And then for undiagnosed, there is we do have undiagnosed people in Nottingham and Nottinghamshire, and absolutely we need to reach out. That is the communication, that's the messaging again, and how we collectively across us all really understand the risks around diabetes and really support that communication. I don't know whether
I'll just give a quick update. So the very low calorie diets, the Diabetes UK conference this year, they've now presented 5-year follow-up data. So if people, and am I right, Hazel, that if you are referred to the NHS low calorie diet programme, then the meal substitutes are provided without any cost to the participants. So there is no cost if you are referred in. And the data now, so the people who took part in the initial research and completed the very low calorie diet, 50% of them, so half of them, reversed their diabetes. So it went away. And what's really, really important is we've now got 4 and 5 year data. And in the vast majority of those people, their diabetes has not come back and they have not regained massive amounts of weight. And it's not just the diabetes that's gone away, it's the high blood pressure, it's all the other stuff that they were having to take. So if you can tolerate it, and it's not an easy ask because it's 3 months of living on meal substitutes and then food being introduced very gradually, but it is a very, very effective treatment. And if we had a drug that reversed type 2 diabetes in 50% of people, the company that made that drug would be worth a gazillion pounds. And then I take your point about the takeaways, and again, this is something I don't know whether as a council this could be looked at as a wise thing, but just as an observation, we've got the Beckett School down the road with a nice big new development that's been built there that contains 3 takeaways next to a secondary school. So what could we do as a system to say, with our planning rules, you cannot open a takeaway within X amount of distance from a school, because young people are going to come out at lunch and they're going to go straight to the cod scallops and help themselves to fish and chips. If you could have them the most healthy deal on, but we know what young people are going to do. So how do we help people make the right choices?
Something which I would like to add about the low calorie diet is that, yes, this is something which is a part of the national program, that anybody who is having a diagnosis of type 2 diabetes within the first 6 years, they are going to be offered the low calorie diet. The reason being is that within the first 6 years, there is more chance that we can bring the diabetes into remission. But we have to be really quite careful and realistic about this as well, is that the low calorie diet involves a person having 600 to 800 calories a day. And when the person is having that, what does the brain really recognizes that yes, you are in famine, and it would make you eat food unless and until we provide this with a psychological support. And I think it is that psychological support which is often lacking, where a lot of these programs which we have been able to put in have not succeeded because that psychological component was lacking. So a lot of these patients would require that psychological support to overcome that feeling, that overcome that brain, and who's giving the sensation that, look, it's not a famine, we are in a controlled environment. So that is something which we find that locally as well as nationally, it is that psychological support which is being provided to the people who are living with diabetes that is nowhere adequate and that's where a lot of these programs do not achieve the success that they should be achieving.
Thank you very much. Vice Chairman.
Thank you. I've got a 3-year-old, and I got gestational diabetes. And my understanding is that means I'm more susceptible to getting it in the future. But literally, had my daughter, had to do a blood test, prick my finger straight after having it, and nothing's been mentioned to me since. There's no information given. And you talk about prevention. I don't know if there's more that we can do to give people information about prevention, especially when they're in that situation where you've had sort of an episode of diabetes and such, and then it's gone away. I just don't know if there's more that we can do with prevention as a whole, but I just know on a localised level, I know that I'm now susceptible to it, but I've absolutely had no information since then. I don't know if there's something that we can do to help people.
Yeah, I think once you have the diagnosis of gestational diabetes, you are at a much higher risk of developing type 2 diabetes, and you should be offered a 6-monthly HbA1c at least. And if it is in the normal range, then at a later stage it can go on to an annual. So again, this is something which national programs are being developed at this moment of time. They are not of the level that has a widespread usage, but they are still being developed. And gestational diabetes is something which is being, a lot of research has already been done, and now hopefully in the coming years there is going to be more information and more guidance around this.
Yeah, thank you.
And there is an argument for saying that if you've had gestational diabetes, as Rahul said, there's such a higher risk of getting it, that therefore you should be automatically eligible to join the diabetes prevention programme. And I don't know, that's potentially something we could look at as a system in terms of how do we increase and widen access so that people can self-refer, because the diabetes prevention programme is something that people can self-refer to look at. And it was interesting, just maybe just one final thing, it's kind of just to put it out there. So we've talked a lot about type 2 diabetes. Type 1 diabetes is very different. It's what's known as an autoimmune condition, where the body's immune system decides your insulin cells are germs, slowly kills it off, and that process starts in childhood, but you might not develop type 1 diabetes until you're in your 50s. There is a research project going on at the moment across the Midlands, and Nottingham is one of the centres taking part, giving families the option to test to see if their child is at risk of developing type 1 diabetes at some stage in the future. And up until now, we said, well, what's the point of knowing? Because there's nothing you can do about it. You can't stop it. But there are some new treatments coming through, and there is a treatment that was licensed for use in the States at the end of 2020. I've lost track of the years. 2022, saying that that has been shown to potentially prevent type 1 diabetes. So there is that potential to prevent it, but also we have been able to show from studies elsewhere that if families know that their child is at risk of it, then they know the symptoms, and then they present much earlier, because 1 in 4 children and young people newly diagnosed with diabetes will arrive in hospital really, really unwell and needing a drip and sometimes even intensive care. Whereas if we catch it early, we can start insulin early, and it's a much less traumatic experience for the family. So we are running this project. It's called ELSA, as in Frozen. So, and we will screen any child between the ages of 3 to 13. It's a finger prick test. If anyone's interested, if they want to contact Hazel, and we're going to do some comms anyway from the trust. We're trying to work out if we can get our mobile research unit, I'm not allowed to call it a research bus, but it is, park it in Market Square over the summer and just have people to drop in. There's a lot of logistics we've got to sort out before we can do that, but there is that possibility that in the next 10 years we might actually be able to prevent type 1 diabetes, which is really exciting.
Thank you. Councillor Turner.
Thank you, Chair. Prevention, in my opinion, is the best cure. There's no remit for yourself for that. Well, the vast array of skills that you have within the diabetes system over there, but there's no remit for you to work with schools. So, it's a straightforward question, really. How do we get the two people working together.
Who's got an answer for that one?
And there is absolutely opportunities as the ICS, and I think it does fit with the priorities within the joint health and wellbeing strategy. So it's just really having that focus on diabetes, though, as part of that.
Thank you. Councillor Anderson.
Thank you, Chairman. I have a few questions for the panel, if I may. So on page 16, 2.6, the paragraph reads, in Nottingham and Nottinghamshire, 85% of people with type 2 diabetes have at least one other long-term condition. 53% have two or more. So as Councillor Eddy and Councillor Turner have just said, prevention has to be at the sort of forefront of tackling this. So I'm just wondering whether things like exercise by prescription, Councillor Creamer mentioned his support group. I mean, could things be offered like a free subscription to things like Swimming World, Weight Watchers, where people meet communally, and there's a sense of support again there for people to talk about perhaps the things they find the most difficult. And to meet people that are in the same situation as themselves. By everything else then that happens once people have it, it's not almost too late, but you know the damage is starting to be done then. I just feel we need to be more proactive and get in there first before it starts to happen. Thank you.
So I'm part of the Active Hospitals group. NUH got a small amount of money from a central group just before COVID, which was designed to try and promote activity across the board. And so we've been looking in various areas, and one of the areas that we were looking at is in the people with fatty liver. So the commonest reason now for liver failure in adults is not alcohol-related liver disease, it's obesity-related liver disease. And so there was there was a move to set up an exercise group, very basic sort of walking group, supportive group, to provide peer support for people who attend that clinic and attend that service. And the group was all set up, and they couldn't get a single person to sign up and join for it. And I think one of the big issues is there's a huge amount of stigma around being overweight, and that which again is a societal issue. And I could make a slightly flippant remark and just ask how many people in this room do the recommended 30 minutes of moderate to active exercise every day. And I suspect that not everybody does, but people try. And so it's how do we make that easy? So we can offer it, but you can take a horse to water, but you can't make them drink. So I guess it's, certainly I think there's not a reason not to try and not to offer it. And our response to that is, well, clearly what we are offering is not right, and we're offering it in the wrong way. I think if you tell people they need to go, they're much less likely to do it. So it's like, well, how do we reframe it? How do we make it interesting? How do we make it something that people want to do? So these are things that have been tried. It's just the solution is often not as easy as you think. And everyone talks about wanting peer support. And I think older adults are better at joining in with that. Young people hate talking to other young people about anything until you get them in a room together and you drag them there and you force them, and then they absolutely love it, and then they all form WhatsApp groups and they go out and meet all the time. So it's that, and I think naturally it's that sort of, I think there is that stigma and that anxiety that goes with any condition that's related to obesity, and we need to change how we talk about it and change our language about it, and try and get away from this feeling of blame and it's your fault, and actually whereas it's not, but it is something you can do something about. And I don't have an easy answer for that, I'm afraid.
I think what I would say is that among the whole of the diabetes population, 91% have type 2 diabetes. And in that 91%, almost 85% of the patients do have obesity. So I think it is that approach to how to manage obesity that is a more fundamental issue here. And yes, there are lots of conversations which are happening. There are lots of conversations with regards to the medications, which recently one has seen a massive increase in. But they have to be done in a manner which is far more scientific, which works, because clearly we have seen that managing the obesity is a far bigger task as compared to managing type 2 diabetes. And it is something where we have not been able to find answers to that. How do we approach that? And as a result, there's a lot of chances that if we don't bring the various agencies together, it is likely that it is going to be managed by different people trying to do different things individually. Some might work, some may not.
Thank you. Did you have any more questions, Sinead? Because you said you had one or two to ask.
Yes. I just wanted to ask you something from a relatively personal level. So I'm a type 1 diabetic. I have been for 25 years. And my last 3 years worth of appointments have been online, face to face, digital appointments. And I haven't seen a diabetic, your injection sites, your feet. I have had my eye test. I haven't had any of those things done in the last 3 years. So I just wonder, is there going to be a plan to bring back face-to-face appointments?
So as far, we certainly in NUH, we are all face-to-face if that's what people want.
I've requested them, but they're still not.
So it should be, it certainly should be. So and certainly all the appointments that I do in the young adult service are all face to face. So they and all the clinics are running face to face and have been for many months. So I would recommend ringing again and requesting, because there are 10, 20 lists running a week for people with diabetes that are all face to face in the treatment centre. And I don't know how it's set up in the city, but there should be no reason for you. If you want a face-to-face appointment, we should be offering you a face-to-face appointment, and it is absolutely down to the individual to choose what they would like.
Okay, thank you.
And I think all the type 1 diabetic patients are eligible for the continuous glucose monitoring, no questions asked. So there is nobody who is not eligible for the technology.
Yeah, I do have the Libra sensor.
And of course, the hybrid closed loop NICE technology assessment will be coming out in the autumn, which hopefully will extend access to the artificial pancreas system for people who are interested in it. With 2/3 of our young people who use pumps in the paediatric service are using the artificial pancreas, which is probably one of the reasons why Nottinghamshire is consistently the best performing paediatric unit in the country in terms of diabetes outcomes.
Thank you. Councillor Grant.
Yeah, just a couple of questions, Tabitha, probably towards you. Sorry, but you mentioned the schools in particular, Beckett, right, and the takeaways. Well, in my thing, there's nothing you can do about planning. That has to go through. You need to be lobbying as MPs for things like that. But my concern is, A, we seem to have no money. B, what is his plan going forward? I mean, again, the children, as you say, yeah, you can teach them to cook, but in deprived areas, you can, pardon the pun, throw them a load of Walker's crisps and they'll eat them. Well, I'm not being rude. That's what children will naturally eat, what they like. So is there a plan for education around that? And the other thing to Dr. Mann is, we, in Stafford in particular, we go into these NHS apps where you're supposed to go in, and a lot of older people haven't got these apps, have they? Because they haven't got the phones. So I know you're saying we're going forward, but listening to everyone around here, there seems to be a lot of miscommunication where people don't understand, well, how bad diabetes can be. As Councillor Wilmott
you can end up with your leg off or anything, can't you, or your arm, and I don't think people realise that neither. So what is this plan going forward to get it out there? Because it's rising, as we've all said, very quick, isn't it? So have we got, in other words, sorry, a 5-year plan, roughly?
So we've got a 5-year plan for what we can do in health, but the wider community stuff, there's not much we can do about that, which is why it was really exciting to come along today. And although, okay, so planning at a top level is MPs, but actually local planning laws can be set by local planning committees. So my ask to people in this room is that you are speaking to your colleagues and you are lobbying and saying, well, why can't Nottinghamshire, and obviously there will be appeals, etc., but why can't you say, well, actually, this is what we want to do and we want to set a plan. I'm very naive. I don't understand how politics and councils work, but my ask to you is why can't we be bold in Nottinghamshire and say, well, actually, our local planning rules are going to say we don't want to approve any new takeaways within X distance of a school, for example. So things that have been shown to work in the past. So when we had Sure Start centres and things like that, where we were working with these very deprived families from a very early on and teaching, because if you've never been shown how to cook and you've never known how to, you're not going to take that to children. And if you're working 3 jobs, it's much easier to bung your kids a packet of crisps and a smoothie than to sit down and say, oh my goodness, I've got to take time. But actually you can cook a meal. And I'm someone who has always cooked from scratch, has always worked full time, but I was lucky because I was taught to cook, and I can cook a meal in the same amount of time it took me to warm up some fish fingers and chips. But I appreciate that that is not a wide skill. But there are things as a community that we could look at and work at, but it is going in at day one. It is in those Sure Start centres that sadly there aren't so many of anymore. And I know that we complain in the NHS that we've got no money, but I know compared to local councils, we're awash with cash. Because we've got Anthony May, who's now our new chief exec, who never ceases to remind us just how hard it's been working in local authorities for the last few years. So I'm aware that we are in a very challenged system. But are there things we could do as a community in Nottinghamshire a bit different without extra money, because there isn't going to be there? So what could we do differently? And it might be trying a pilot in an area or something like that. I don't have the answers, but I've got lots of questions, and we are always happy to work with anybody in terms of if they've got an idea and go out there and do it.
Thank you.
Can I just mention that we have got the joint forward plan, which is a 5-year plan for the NHS, but that's been done. There's a really strong emphasis of prevention in that, and long-term condition management. That plan has very much been put together with public health, and this is really about working very closely with public health and using the expertise of public health colleagues to really understand how we can make a change and have diabetes at the forefront of it.
Thank you. Councillor Kramer, you wanted to come in again?
Very, very quickly. I'll just say about the planning laws and whatever. Just to explain that at the moment, the district councils are actually going through their plans, their 5-year plans, their plans for what's happening. Now the schools, a little bit of education, just time. The schools come under us, Weekend Planning Commission for Schools. But outside that, it's the district councils. So outside the school area, if there's houses going, shops, it's the district councils. So on this one, it would be worth if you've got the slide. It'd be nice if we could have the slides anyway and pass them to our colleagues. But if you did the same sort of presentation for the district councils, if they would have it, Gedling, Mansfield, Bassetlaw, etc., etc. They're the ones who are literally putting their local plans together at the moment, and they're the ones that decide what's going to be built where and what rules are going to apply. Like there will be no shops in this area, or there will be not. So right at this moment in time, it'd be worth actually having words with district councils to try and influence. It may not work.
To anyone.
Yeah, it may not work, but they're the ones you need to have to about planning about facilities near schools.
Yes, I think I would agree with that, Councillor Kramer. And when you see new developments coming in, that's usually where the big boys come in and say, we'll have a McDonald's or we'll have a whatever. And it's probably where the new developments are. And when it's being discussed on planning. As a member of Nottinghamshire District Council Planning, it's something that I'm always looking out for, actually. Yes, Councillor Turner, you wanted to say something?
Yes, very briefly. Children, devices, whilst I've been sat here, my smartphone's been telling me to move around.
What, sorry? Your smartphone has been...
My smartphone's been telling me to move around.
Ah, right, okay. Well, you can go and run around the block. I'll opt to stay here. It's raining out there. Right, so have we any more questions, members? Councillor Pringle, did you want to ask anything? Because you're our usual addition to this committee. It's very nice to welcome you every month.
Thank you, and it's always a pleasure to be in your company, as well. My reference is to Newark Hospital.
Yes,
so do you
yes,
talk
I
about
realise
that now or
that.
later?
Right, so thank you very much to all of you, to Hazel, to Tabitha, and to Dr. Mohan. Thank you very much indeed. Now, our remit for this really is to listen to your brief, which we've done, and to decide when we might like to see you again, as Hazel will recall we have done. May I suggest that you mentioned, Tabitha, you mentioned about progress in children and young people. You were hoping to have some more information available, yes?
What precisely?
Sorry,
It's with respect to the Commission of Specialist Services.
Oh yes, so the sort of technology and stuff that will be September time. That will come out, but that's not just for children and young people, that's for everybody with diabetes.
So do you think, right, I thought it was just children, could we suggest that you probably come back in 6 months and let us know how that's doing? And Hazel, will that involve you as well?
Well,
Tabitha
I don't know. We're going through a restructure.
Tabitha's just said it's across the board.
But we would have ICB representation to support. So yes,
can I ask that we look at it in 6 months, and Noel, our officer here, will negotiate with you. Yes.
I just wanted to have a quick word. It's specifically referenced in the report about reviewing current provision, particularly among those aged 16 to 25, and ideally commissioning specialist services for this group. So we just want to get a sense of the timescales for that happening, to see whether there was a role for this committee for that, and then separate to that, perhaps look at coming back at a point in time when you feel that the plans that are in place are going to bear fruit in respect of halting the tide, or at least, or getting a sense of what you've put in place is going to work. Initially, we're thinking a year, but if you could just advise on the timescales for that specific piece of work.
So I think this is the NHSE monies that are coming out. So I'll let Hazel speak to that.
Yeah. So it wouldn't. It's not a significant change that would come here in isolation.
Okay.
It's more around how do we manage services as opposed to it being a significant change. So if we came back in 6 months to provide an update on progress in the areas that we've outlined, but specifically in some of the things that we know will be happening either around the technology or around the pilots, we could do that.
Yeah.
Well, we'll leave you to negotiate with Noel on that. Is that all right?
Yeah.
Okay.
So thank you very much to all three of you. That was interesting insight to everybody, and some of the people on this committee are new from when you came last time, Hazel.
Yeah.
So very useful.
Thank you very much.
Thank you. Thank you to all of you. Thank you. Safe trip back to NUH.
I'll just go see if we've got this here.
Could have got a blood test.
Just show us your safe.
But it's because it was the middle of lockdown, isn't it?
Yeah, same everything, isn't it? I'm just going to text Caroline and tell her it's big.
okay to re-begin the streaming?
I'm sorry. I have been advised in a letter which was circulated with the agenda that the extension is required for a further 12-month period, which will take us to the end of June 2024. So we have Lucy here today from the ICB to explain the rationale for the extension and to advise on next steps for the wider changes at Newark Hospital, which of course is all very exciting for the people of Newark. It's just a case of bringing it to fruition. So over to you, Lucy, just for an explanation.
Thank you. I will be very brief. We initially requested an overnight, so it is an overnight closure between the hours of 10 p.m. and 8 a.m. for the new urgent treatment centre at Newark Hospital on the 6th of April 2020, when it became extremely apparent at the height of the COVID pandemic that we couldn't safely staff overnight with medical staff. That situation regrettably has not fully relieved itself yet, insofar as the trust that provides overnight medical care, that provides medical care to the Newark Hospital, which is Sherwood Forest Hospitals NHS Trust, is still not able to staff that rota overnight. So we are requesting a further 12 months extension, as the chair of the committee has said. In the work that we are doing in the meantime and continue to do is to be absolutely clear about our vision for Newark Hospital, so that any conclusion to this temporary extension should be taken in the context of the future of Newark Hospital in its broadest sense, which we continue to see as an absolute jewel in the crown for our local health and care economy. And we are actively working to develop a portfolio of additional services that will be provided out of Newark Hospital to the local population, sort of very much focusing as well on planned care and diagnostics. We are confident, it's clearly we would have liked to have resolved this matter by now, but we haven't, but we are confident that within 12 months we will have been able to engage you in meaningful dialogue about the overall future of Newark Hospital, the services that we want to continue to grow for the local population. Thank you.
Thank you, Lucy. Does anyone have any comments to make on this, please? Councillor Bailey.
Thank you very much. So, I suppose my main question is, last year essentially there was the request to know that it's going to be another 12 months, coming back to the same point again this time. I suppose my question is, what's changed in the past 12 months that you didn't foresee 12 months ago? I'm just conscious that we don't want to just be noting extension every 12 months, and it's just nothing changes. You know, if it's not able to happen, I think everyone would rather know now rather than 12 months down the line when there's another extension.
So yeah, I absolutely agree, and it has taken us longer than we would have hoped to be in a position. But what we want to do is to kind of set the future for the hospital for, you know, the next sort of generation, and there is lots of work behind that. The Newark Urgent Treatment Centre is a part and will be a part of the offer from Newark Hospital to the local population going forward. I can, you know, say that categorically. The work that we are still in the process of developing is absolute clarity about the other services that we want to commission from, and Sherwood Forest and other partners feel able to provide from Newark. So it's a process of just developing those. Some of those are subject to, as you heard in the previous discussion, we're about to have our first 5-year joint forward plan, which I think does give us some fairly clear signals about the kind of services, particularly around plan care and diagnostics, that we need to provide from Newark Hospital. And I am confident that we will be in a position to have that dialogue with you, and we will not be coming back to ask for any further temporary extensions to emergency arrangements.
Thank you, Lucy. You want to come back?
Yes. So in terms of for the past 12 months, you mentioned it was continuing to develop. Does that mean that the plan to develop is going slower than what you originally thought 12 months ago? Again, I suppose my question was, what's changed in the past 12 months? So I just want to make sure that, if it was being developed, as you mentioned, it was going on schedule, in which case the request 12 months ago was probably too slow. You didn't request enough months. I suppose I'm really disappointed in the fact that we've got these ongoing 12 months requests. I find it frustrating. I can imagine residents find it equally frustrating. I just want to get to the bottom of why it's 12 months.
Well, obviously, so the original request for temporary closure was very much a consequence of the COVID pandemic. You are right. With the benefit of hindsight, we might have foreseen, or we possibly couldn't have foreseen, that with the publishing of the system's first integrated care strategy, which does make some very clear commitments to new ways of working, which we couldn't have envisaged a year ago. So the integrated care strategy was we hadn't produced our integrated care strategy this time a year ago. We hadn't started the thinking. We have subsequently published that in March this year. We are about to publish our joint forward plan in June. So these are two real sort of landmarks, I think, in the way we're planning services. As an ICB, which of course, we weren't an ICB a year ago, we were a CCG, we were working under a different regime. So I think I would say, if we knew what we know now, the context that we would be operating in now, we would have asked for 2 years. But I am confident that we know enough now, as I say, through the integrated care strategy, the joint forward plan, and our sort of ongoing analysis of population health needs. There's a national recovery strategy, there's a national strategy for urgent care. I think we have got all the building blocks that we need now to be able to formulate our proposals for growing services to meet the needs of the population in Newark.
Thank you, Lucy. Councillor Martin.
Yeah. Yes. I don't know where we are with this, because I'm trying to determine whether it is actually an inability to employ staff, or whether it's more financially driven. Over the Sherwood Hospital Trust, and I think if it is financially driven, it's having a detrimental impact on the population of Newark, which is expanding. I mean, I think they built somewhere around 10,000 new homes are planned around Newark in the foreseeable future, if not already. And it's a 2-hour round trip, from Newark to Kingsmill, and the other nearest urgent care centre is in Lincoln. Or they're coming down to Queens, and I think we touched on this before. We spoke about Newark being of major importance, because when that unit is down overnight, it has a detrimental impact on the people in Mansfield and Ashfield, because people are coming across that, and it's a good urgency. It's a good emergent A&E at Kingsmill, I'll grant that, and the primary care is fantastic, but I think the people of Newark 3 years down the line should definitely have the same facility, because it warrants it. And I'm struggling to work out here whether this is financially driven or whether it's your inability to recruit staff. I know there's a national shortage of nurses, and I know that is an issue, but 3 years down the line, surely we should be somewhere hitting the mark.
Yes, so I can say categorically it's not a financially driven situation. Absolutely, categorically not. I think, just to pick up on your points, just Newark is an urgent treatment centre. It has been an urgent treatment centre since 2009. It's not an accident and emergency department, and in hours, people requiring accident and emergency support would do travel to Kings Mill, and I think we do recognise, and it's nice of you to recognise that they do get very good service. So it is an urgent treatment centre, and as you rightly say, there is an urgent treatment centre co-located with the accident and emergency centre at Kings Mill. We do have good out-of-hours primary care in Newark, and we are able to support people out of hours overnight needing urgent treatment centre type care. But if they need accident emergency care, even if that facility is open overnight, they would still go to Kings Mill. We do have quite a lot of data about the demand for urgent treatment centre care overnight, and it is very, very low levels of demand. And we don't feel, which is why we would, you don't enact an emergency closure unless you feel you have no choice. But we definitely took into account the impact of that emergency closure on activity, urgent treatment centre activity overnight, and there it is very, very low. And we do believe that there are other services for the population in Newark that are able, whilst there isn't that facility, urgent treatment centre, particularly overnight, to support patients. But as you know, the A&E in Kings Mill serves the population of Newark 24 hours a day and will continue to do so.
Thank you. I think as the member here who represents Newark, I can say that the residents of Newark obviously will be pleased when the extension time makes it that we can have a 24-hour service. But I have to say, until that time happens and we do have it up and running, and after all, we want it up and running correctly, not just rushing to get it done for one reason or another. I think it's possibly, unless I've misunderstood, it's a case of when we first had to extend it, we extended for the year because that's what it had to be. And it's just unfortunate that the year keeps coming and probably they haven't got everything ready to go. Perhaps if we'd had another 6 months before we had to consider this, it might well have been ready to be up and running. I think it's the timing that we legally or whatever have to agree to this. But as a user of Newark Hospital, I recently had a chest infection that wouldn't go away, and the doctor sent me for a chest x-ray just to check. I rang to make the appointment. I was in within 2 or 3 days. I went into Newark Hospital. I hardly had time to take my top off before the radiographer came out and said, "I'll have you in now." I was in there for a couple of minutes, came out, I was back in my car within a quarter of an hour. I mean, to get that type of treatment is absolutely superb. Everybody in Newark speaks very highly of Newark Hospital. It's clean, it's efficient, the staff are extremely pleasant, and I am one person who would like to see this up and running, but I'd like to see it up and running when the diagnostic various equipment is in place and we can go and use the hospital as we should. But in the meantime, I don't have any problem with Newark Hospital. I recommend it, and I was only with somebody yesterday who was saying they'd been into, I can't remember what it was about, but they mentioned they'd been into the urgent treatment centre and how efficient it was. So I think we're very fortunate, and yes, the people of Newark would like to see it up and running, but if they're not ready to set it going yet, then I'm afraid we have to take what we are offered and hope that this time next year it will be up and running. Okay, thank you. Councillor Martin.
Yeah, I'll just potentially probably make myself clearer. I'm not in any way dismissing either services at either hospital. You know, I know they're excellent. What I'm trying to get to the bottom of is have inflationary costs, you know, interest rates and stuff like that. Have national inflationary costs impacted on the financial ability of Sherwood Forest Hospitals Trust because of the PFI contract at Kingsmill? You know, are those inflationary costs impacting on the delivery of services? Because you just actually said, Lucy, there, looking at the data of people who use the service at night is not warranting keeping it open. So therefore, that says to me that this situation is not going to resolve itself by a time period, because over the next 12 months, we'll have the same data as we've had over the last 12 months, and it'll only be pro rata inflated by the expansion of population, and that will be taken into account over that next 12 months. So I'm just concerned that we're not just running to stand still to get the same answer next year.
Lucy, would you like to come back on that?
I can absolutely reiterate that it is not any more than public services in general are under financial pressure. There is no local financial pressure that is driving any of these decisions. And as your colleague quite rightly said, we should and we must now move within this next 12 months to be really clear about what is the health needs of the population. You point out population growth, and it's not just population growth. We need to analyse the age profile of that population to understand what kind of services that they can benefit from. The needs of the population has changed quite significantly post-COVID. So the work we're doing now, and I'm happy to take. There is always a perfect time to do it, and I think what I would say is if nothing fundamental changes in the external environment, we have everything that we need now to be able to bring together a proposal for you to consider, for us to consider, about what the population health needs for the Newark population are and what services we can provide. And we are really hopeful that we can bring new services. We have, I haven't sort of come with all that information today, but there's been a demonstrable increase in services provided from Newark over the last 10 years, and those services will increase. But what we need to do, it's not about money, it's about need. And what we have to do is we must make sure that the skills and resources we have are directed to provide the services that give the greatest benefits to our population. It is complex, but I think we are in a position now that we will be able to come back to you ahead of June, because we don't want to come back to you, I don't want to be here in 12 months. I want to be here talking to you ahead of the next 12 months, so that we can look at Newark in the round and be really clear to you all about this is the service offer that we think best meets the needs of the population. But I can absolutely categorically say there is no locally driven financial context to how we're developing that general model.
Councillor Creamer.
Yeah, she's actually literally just answered part of my question. Part of the question was going to be are we pretty well sure that it's going to open in June next year? And up to that point, because of all the previous unseens, would it be worth coming back in December, January this year to actually see that everything is going to plan, going to progress, and there's no further actual surprises, etc., etc. So literally just answered the question. But yeah, I would be happy to see it come back December, January, just to update.
Yeah. Would you be happy with that, Lucy?
Sorry, yes, of course, and yes, absolutely. I would absolutely be happy to do that.
I have an update, Christmas update. How about that?
Indeed.
Councillor Pringle, visitor to the committee. You'd like a word?
Thank you, Chairman. Thank you for allowing me to speak. Lucy, such a disappointing report to read for obvious reasons, and I'm sure you're disappointed as well. However, on the streets at sea, as a primary disappointment to some people. I had the fortune to be in Newark yesterday. Yesterday evening I spoke to 16 people. 4 of them didn't care one way or another what happened in Newark. Well, the other 12 really wanted to see an expansion to the hospital because of the expansion to the infrastructure, which we know is positive, and all the housing developments, which again we know is positive. So the healthcare provision obviously has to be seen as a positive, and to receive a suggestion that this is now going to take a further 12 months, taking it into a 4-year period, really is a stretch. I think Councillor Bailey and Councillor Martin have suggested, we really need to be on top of this. And I would hate to come back in December of this year to say that we've stumbled again. And I think really in the report as well, the safety that's mentioned, that puts the scares up people really, because we recognise that there's a safety issue with provision of nurses and doctors accordingly. But I want you to clarify that for me, please. What exactly is the safety issue? And I know you said that we'll come back in June and we will have this facility and we'll be looking to the future development of it, which I think is going to be really important. I think you'll preface that in December or January when you can acknowledge it. But we need to see after 4 years a future vision for this facility as well. And I get that we deal with Kingsmill, and I get that we deal with other big hospitals. I think this really is going to be, in your words, a jewel in the crown, and the residents of Newark in particular and those surrounding areas really want to see that. So if you can respond, I'd appreciate it. Thank you for letting me speak.
So again, I can only acknowledge that people will be disappointed at a further year, a temporary extension, and I do acknowledge that. But I do want to also say on the record that is absolutely not an indication of our commitment, not being committed to growing services from Newark Hospital, and we have a number of things underway, which I am confident we will be back to talk to you about ahead of June. So it's just slightly too early to tell you everything, but I can tell you we are looking at a vision that will make Newark Hospital more vibrant than it's certainly been, in my time in the NHS in Nottingham and Nottinghamshire. So I think we will be able to provide you with kind of sort of crunching through all the kind of the numbers and looking at the population health need and looking at where we where we think additional, and I say particularly around planned care diagnostics, where we think we can increase services into Newark Hospital for the population of Newark Hospital, but also, we know people already choose Newark from outside of Newark for all the reasons that Councillor Saddington said. It's a nice environment, it's got great staff, it's easy to park, as you know, there's additional car parking being provided at the moment. So we really do want, and we will, provide a vision for Newark Hospital that grows services at Newark Hospital, and we will be in a position to share that with you over the course of this calendar year. So I do, I want to assure you that is where we are. In terms of safety, I'm sort of just checking the note I produced. I don't think we've made any explicit reference to concerns about safety. We are confident that we are able to provide safe services from Newark Hospital currently, and that those services that also support residents in Newark that are not provided from the hospital, like out-of-hours primary care, like the A&E at Sherwood, continue to be safe. So we don't currently have any safety concerns. So this isn't driven by any safety concerns either. But yes, I can definitely commit to a very sort of positive future for Newark Hospital.
Because
you want to come back?
If I just a quick one, and I don't want to answer this. Well, the safety is referenced in the accompanying letter.
Anything to answer? No. I think what we can say is, Lucy, that Newark and the surrounding district are really looking forward to the hospital opening when it does open with more facilities. So I'm holding you to it being worth waiting for. And I'm certainly holding you that Newark and all its residents around will hope that it's been well worth the wait. Councillor Wilmott.
Just a point of clarification. This is an urgent treatment centre, and it is the overnight part that is closed at the present time. I'm just saying, but you did say that in any case, even when the urgent treatment centres open, all serious emergencies will still go to Kingsmill and Queen's Medical Centre. Is that correct?
Yes, that is correct. It is. That has been the case for at least 10. Well, yeah, certainly. I think it's 2009, and that is very much in line with national policy that accident emergency departments need to be provided on a scale that you can provide the appropriate infrastructure, the critical care, the coronary care, the advanced scanning, and the sort of multidisciplinary clinical support. And that's not been a model that's been provided from Newark Hospital. So the urgent treatment centre has a very specific. I mean, it's again, there's lots of national sort of policy clarity about what an urgent treatment centre should do, and the national guidance is that it should open at least 8 till 8. The national guidance doesn't require urgent treatment centres to be open overnight, but I can give you assurance that Newark operates fully in accordance with the requirements of an urgent treatment centre.
Thank you, Lucy.
That's highlighting.
All right.
Yes, thank you.
Has that answered your question? Anybody else got any questions? Right. What we have to do, members of this committee, is agree to a 12-month temporary extension. And I'm going to take a vote on it because it is a difficult decision for everybody. But we've heard from Lucy where they are with it. We hope she'll come back at Christmas and give us a Christmas surprise and tell us that it's going to open earlier than possibly planned. So can I take a vote, please, that we're all prepared to accept this 12-month extension, but hopefully it could always be a bit earlier. All right, Lucy, is that reasonable?
Yes, I mean, yes, I am, at your disposal to come back and update on the future of Newark Hospital, so that we do not request any further temporary closures of the urgent treatment centre overnight.
So let's take a vote on it, members. Are we all prepared to accept this? Sorry? Yeah?
It is to note the decision.
It is to note,
yeah.
But I want to be sure everybody's happy with it, because I know that there are people who've got concerns. So can we just take a vote to make sure people are reasonably supportive of it? It's really that you've got... Pardon? Well, note it. Well, you've also got to support it, I'm afraid, because we don't have an alternative. If it's not ready to open yet, you don't have an alternative. So we're all happy then. If you don't want to vote, we're all happy to note it. You're happy to note it. Right, okay. That's fine. Lucy will come back at Christmas with a surprise, I'm sure. We'll put the pressure on you, Lucy.
Exactly.
All right. Thank you very much, Lucy. That was short and sweet for you this time. I think you might be here longer next month. So I think members, thank you, Lucy. Members, moving on. Noel is going to discuss the work programme for July, which is changing. We will have Lucy back in July. See you in July.
Thank you.
Yeah, thank you. It's just as a matter of courtesy to point out that the work programme that we noted back in May has had to change somewhat. For this meeting, we had hoped to have something more substantive on the Newark Hospital. It's not the case. We've heard the reasons why, and that will be put into the mix for our work programme later this year. As a result, we've of a request as well from the ICB to have a single item meeting on the development of tomorrow's NUH, because that is such a wide overarching issue. The views taken that that's what we should have for the July meeting. That does mean moving EMAS to consideration of EMAS performance to the autumn. I've not yet been in a position to definitively schedule that plus the other items that we need to slot into our meetings for September through to the end of the year. But that is that's a key task for me in the days and weeks to come. The other thing is I wrote to members asking if you had any items that you wanted specifically on the work programme for the coming year, in addition to what's already on there. And I'm grateful for the response that I had to date. But if there is anything else, that now might be the time that you might want to flag anything up. Thank you.
So with that, members, we'll bring the meeting to a close. Please note the early time that you're finishing today, because next time, I hasten to say, it might be a bit longer. No, you haven't got 3 months off. We've just got to make sure who can come on those dates. And we seem to have an awful lot of people returning, actually. So could we have the live stream turned off, please?